I was standing at the nurse's station just going through charts. It's the kind of routine work you do to keep your hands busy. I'm 34, and I've been a trauma surgeon for a while, but I've also been the person people avoid talking to for the last 3 years. It all goes back to my time overseas, a night that ended with me being labeled as reckless and dangerous. So, for 3 years, I've been stuck working in the background, handling the cases other doctors didn't want, while they got the more high-profile, savable ones. Ben Carter, one of the ER residents, walked up to me, looking nervous. "We've got an incoming trauma," he said. "Multi-vehicle accident, male patient 32. Looks like massive internal bleeding. They'll be here in 2 minutes." I just nodded and started walking towards the trauma bay. This was my specialty now. The desperate cases. The ones where everyone already expected a bad outcome. It felt like my reputation was so ruined that I couldn't fall any further. So they gave me the falls. The ambulance doors burst open, and the paramedics rushed in with a patient whose vital signs were already crashing. My hands started moving on their own. Airway, breathing, circulation, the standard checks. But as I looked at his injuries, something about the pattern felt unsettlingly familiar. "Tell me what you've got," I ordered, cutting away what was left of his shirt. "Mark Jennings, 32, one of the paramedics said, rattling it off. "Ejected from the vehicle, blunt force trauma to the chest and abdomen. His pressure is dropping fast and his heart rate is spiking. We've lost him twice on the way over." When I got the shirt off and saw his chest, my blood just turned cold. The injury pattern was unmistakable. A massive cardiac contusion, which means his heart was badly bruised, and pericardial tamponade, where blood was filling the sac around his heart and squeezing it. On top of that, his sternum was shattered, which made the normal way of operating, right down the middle, pretty much impossible. I had seen this exact set of injuries one time before, overseas. It was on Sergeant Leo Diaz, a patient I tried to save with an experimental battlefield technique. He was the patient who died on my table while I was trying to be innovative. "Get me Dr. Wallace," I said, my voice feeling tight. I needed him now because this new patient, Mark Jennings, was going to die just like Sergeant Diaz had, unless I was willing to try again. Unless I was willing to risk what was left of my career on the very technique that had destroyed it. Dr. Samuel Wallace, our chief of cardiothoracic surgery, walked into the trauma bay with that air of complete authority he always had. He's 60, he's seen everything, and he's handled thousands of surgeries. But when he looked at the imaging, even he paused. "Jesus," he whispered, looking at the scans. "Massive cardiac contusion, pericardial effusion, and that sternal fracture makes a traditional sternotomy impossible." He turned to me. "Options?" I felt the weight of the last 3 years pressing down on me. "The standard approach won't work," I said. "His sternum is too unstable. If we try the conventional access, we'll end up causing more damage than we fix." "What about alternative approaches?" he asked. "A lateral thoracotomy might give us some access, but with this much cardiac trauma, we won't get enough exposure to repair all the damage." My hands were steady, but my mind was flashing back to that night overseas. Wallace studied the scans, his face getting more grim. "Without sternal access," he said, "I don't see how we save this patient." "There might be one way," I said quietly. Wallace looked at me, his eyes sharp. "What way?" I hesitated. This was the moment. I could either stay quiet and watch another man die, or I could speak up and risk everything on a procedure that had already failed me once. "A modified substernal approach," I said. "Instead of splitting the sternum, we access the pericardium, the sac around the heart, through a subxiphoid window just below the breastbone. Then we use specialized instruments to repair the cardiac damage from below." Wallace's eyes narrowed. "That's not a standard technique." "No," I agreed. "It was developed for battlefield trauma situations, where traditional surgical access just wasn't possible. I met his gaze. I saw it used once when I was deployed. You saw it used, or you performed it? He asked. The room got quiet. Everyone there knew my history. I was the brilliant military surgeon who had come home in disgrace after a failed experimental procedure cost a soldier his life. I performed it, I admitted, on a patient with this exact injury pattern. Wallace's voice was hard. And he died on the table. Massive hemorrhage during the repair attempt. My voice was steady, even though the memories were clawing at me. It was ruled an unnecessary risk, an experimental technique that hadn't been properly validated. I was reprimanded, and my military medical privileges were revoked. Wallace was silent for a long moment, looking from me to the dying patient. So, he said finally, you're suggesting we try the technique that already killed someone? I'm suggesting it's the only option this patient has, I said, pointing to the cardiac monitor. He's got maybe 20 minutes before there's irreversible damage. Standard approaches won't work. We can either let him die without trying or attempt something that might save him. Might save him, Wallace repeated, or might kill him, like it killed your last patient. I flinched, but I held my ground. Dr. Wallace, I've spent 3 years analyzing what went wrong overseas. I know where the technique failed. I know how to prevent the complications that killed Sergeant Diaz. You know how to prevent them? His voice was dripping with skepticism. Based on what? 3 years of theoretical analysis of a failure? Based on 3 years of reviewing every single detail of that surgery, I said, my voice getting more intense. Of understanding the hemorrhage pattern, of identifying the exact moment where the approach went wrong. Dr. Wallace, I didn't fail because the technique itself was flawed. I failed because I didn't account for the battlefield conditions, the patient's hypothermia, the coagulopathy from massive blood loss, the limited lighting. Here, in a controlled OR, with proper resources, it can work. Wallace just studied me for a long time. Or it can fail again, he said, and we'll both be responsible for this patient's death. He's going to die anyway, I said bluntly. His pressure is dropping. His heart is failing. Without intervention, he's got 15 minutes. With standard approaches, which we both know won't work, he's still got 15 minutes. The only question is whether we're willing to try something that might give him a chance. The monitors started alarming more urgently. Jennings's pressure was falling even faster. Doctor, Ben Carter, the resident, called out. We need to make a decision now. Wallace looked at the monitors, at the dying patient, and then back at me, standing there with 3 years of guilt and a desperate need for redemption on my face. No, he said finally. I won't authorize an experimental technique that's already proven fatal. We'll attempt a lateral thoracotomy and do the best we can with limited exposure. That won't be enough, I pleaded. It's my decision, Dr. Reed. His voice was final. Prepare for the standard surgical approach. We operate in 5 minutes. As Wallace walked away to scrub in, I just stood there, frozen, watching Mark Jennings's vitals continue their downward spiral. I could let it go. I could follow orders, stand by, and watch another patient die with the exact same injuries that had killed Sergeant Diaz. Or I could fight, risk everything, possibly save a life, and definitely destroy what little remained of my career. The monitors screamed as Jennings's heart began to fail. I made my choice. Dr. Reed, what are you doing? The scrub nurse's voice, Chloe's, was full of alarm. I had moved toward the supply cabinet and was pulling out specialized instruments that weren't part of the standard surgical tray. Preparing for a substernal approach, I said. My voice was calm, but my heart was racing. But Dr. Wallace ordered a lateral thoracotomy. Dr. Wallace ordered an approach that won't work, I said, meeting her eyes. Chloe, you've worked with me for 2 years. You know I don't take unnecessary risks. This patient will die with a standard approach. I'm just giving him a chance. Chloe hesitated for a second, then nodded. What do you need? Long-handled forceps, specialized retractors, and the fiber optic scope for visualization. My hands moved with a practiced efficiency, assembling instruments I hadn't actually touched in 3 years. And call Dr. Chen from anesthesia. Tell him I need someone who can handle rapid transfusion protocols. Anna, Chloe said quietly, using my first name, if this goes wrong, Wallace will destroy you. If I don't try, I replied, I'll have destroyed myself. I looked at Jennings, whose vitals were now at critical levels. 3 years ago, I failed to save a soldier because I wasn't prepared for the complications. I won't make that mistake twice. Dr. Wallace burst through the OR doors, already scrubbed, and just froze when he saw my instrument setup. What the hell is this? His voice was ice. Plan B, I said calmly. The lateral thoracotomy will fail. We both know it. This is the only approach with a chance of success. I specifically ordered. You ordered an approach that gives this patient a 0% chance of survival, I said, turning to face him fully. Dr. Wallace, I respect your authority, but I will not stand by and watch someone die when I know a technique that might save them. A technique that already killed someone. A technique that I now understand completely, I said, my voice steady. Dr. Wallace, give me 30 minutes. If I can't stabilize him in 30 minutes using the substernal approach, you can take over with any method you choose. Wallace stared at me, rage and uncertainty fighting on his face. If this patient dies, I said, making the bargain, then I take full responsibility. It goes in the record as my decision, my technique, my failure. I met his gaze without flinching. But if he lives, we'll have validated a technique that could save countless trauma patients with injuries that are currently considered unsurvivable. The monitor's alarms grew more urgent. Jennings was coding. We're out of time, I said. I need your decision now. Wallace looked at the monitors, at the dying patient, and at me, standing there with 3 years of guilt and determination on my face. 30 minutes, he said finally, but I'm observing every step. And if there's even a hint of the complications you had overseas, I'm taking over immediately. I nodded. Understood. As I positioned myself at the operating table, my hands moving through the familiar motions of surgical preparation, I felt time just collapse. 3 years fell away, and I was back in that field hospital, standing over Sergeant Diaz, attempting a technique that would either save his life or end my career. I had failed then. I had lost the patient. I had been branded reckless. But now I understood what had gone wrong. Now I knew how to prevent the catastrophic hemorrhage that had killed him. The question was, would understanding be enough, or would history repeat itself? Scalpel, I said, my voice steady. Somewhere in the back of my mind, I heard Sergeant Diaz's voice from that last night. Doc, don't let them stop you from being great. Sometimes being great means taking risks nobody else will take. I'd taken the risk then and failed. Now it was time to prove that failure had taught me something. Time to prove that the renegade doctor still had one more miracle in her. The scalpel cut through the skin with practiced precision. My hands were moving with the muscle memory of hundreds of surgeries. But this wasn't just another surgery. This was redemption or damnation, all wrapped up in 30 minutes of surgical time. Subxiphoid access established, I announced, working with controlled urgency. Chloe, I need the fiber optic scope. Dr. Wallace watched from his position opposite me, his expression impossible to read. But his attention was absolute. Every move I made was being judged against the ghost of my past failure. Dr. Reed, the anesthesiologist, Dr. Chen, called out. Pressure's continuing to drop. We're at 70/40. That's expected, I said, threading the scope through the small surgical window I'd created. The pericardial tamponade is preventing his heart from filling. Once I relieve the pressure, we should see an improvement. I worked the scope deeper. The monitor showed a close-up view of Mark's damaged heart. The pericardium was tense with accumulated blood, the cardiac muscle itself bruised and struggling. There, I said, identifying the best access point. Pericardial window 2 centimeters inferior to the xiphoid process. Chloe, specialized retractor. As I worked to expose the heart, I felt the weight of the last 3 years lifting just slightly. I was back in surgery. Real surgery. The kind that mattered. Dr. Reed, Wallace said quietly. The hemorrhage point. Where is it? I adjusted the scope, searching. This was the critical moment, identifying the bleeding source before trying to repair it. Overseas, I had moved too quickly, tried to repair before I fully understood the injury pattern. Multiple sources, I said, my voice tight. Small vessels along the cardiac contusion, but the main bleeding is from a coronary vessel tear. Anterior descending, approximately 2 centimeters from the origin. Wallace leaned closer to the monitor. That's a difficult repair from this angle. But not impossible, I said. My hands were steady as I introduced the specialized instruments through the subxiphoid window. The key is stabilizing the heart without causing additional trauma. I worked in silence. The only sounds were the beeping monitors and my quiet instructions to Chloe. Each movement was deliberate, careful, and informed by 3 years of analyzing my past mistake. In that field hospital, I had tried to repair too aggressively. I had assumed battlefield speed was what mattered. I had pushed when I should have been patient. Now I took my time, methodical, precise. Pressure's stabilizing, Dr. Chen reported. 80/50. I saw Dr. Wallace's eyebrows rise slightly. It might have been surprise, or maybe just cautious hope. I kept working, repairing the damaged vessels with micro-sutures that would hold without restricting the heart's function. The technique was working. The approach was sound. And then I saw it, a small vessel tucked just behind the primary repair site, showing the telltale pulsation of arterial bleeding. It was hidden, easy to miss. It was exactly like the vessel that had caused Sergeant Diaz's fatal hemorrhage. There, I breathed. That's what I missed. Missed? Wallace leaned in. What are you seeing? A secondary bleeding source, posterior to the primary repair. I felt cold sweat on my back. Overseas, I didn't see this until after I'd completed the primary repair. By the time it became visible, the patient was already unstable, and my attempt to access it caused a catastrophic hemorrhage. I'd found it, the mistake that had killed Diaz, the hidden vessel that had been my downfall. Can you reach it from your current approach? Wallace asked. I think so, I said, but it requires extending the window slightly and working at an angle that's... I paused. It's difficult. High risk of causing additional damage. Wallace was quiet for a moment. What would you do? Secure the primary repairs first, stabilize the patient, then carefully extend the access to reach the secondary source, I said, my voice steady. Exactly the opposite of what I did 3 years ago. I worked methodically, completing each repair before moving to the next. No rushing, no assumptions. Each vessel was secured, tested, confirmed. Pressure's up to 90/60, Dr. Chen reported. Heart rhythm is stabilizing. I allowed myself one small breath of relief, then focused on the final challenge, the hidden vessel that had killed Sergeant Diaz. Dr. Wallace, I said quietly, this is where I failed before. I'm extending the surgical window now. Wallace just nodded. Proceed. My hands moved with practiced precision, enlarging the access point just enough to reach the problematic vessel. Back then, I had been too aggressive here, caused tearing, created a hemorrhage I couldn't control. Now I was careful, patient, respectful of the delicate tissues. "There," I said, finally exposing the vessel fully. "Arterial bleeder. Easily accessible now." "Impressive," Wallace said quietly. "I see why you couldn't reach this with standard approaches." I placed the final suture, securing the vessel that had haunted my dreams for 3 years. "Repair complete," I announced. "All bleeding sources controlled." The monitors showed Mark Jennings's vitals steadily improving. His heart rate was normalizing, his pressure climbing toward acceptable ranges, and his cardiac rhythm was strong and regular. "My God," Dr. Chen breathed. "It's working." I stepped back from the table, suddenly feeling exhausted. "Dr. Wallace, would you like to close?" Wallace looked at me for a long moment. "You finish what you started, Dr. Reed." As I completed the closure, my hands steady despite the emotional storm inside me, I realized something profound had just happened. I had faced my failure. I had confronted the technique that had destroyed my career. And this time, I had succeeded. Sergeant Diaz was still gone. Nothing could ever change that. But Mark Jennings was alive, and that meant something. It meant I wasn't a failure. It meant the technique worked. It meant 3 years of exile and guilt hadn't been for nothing. "Surgery complete," I said, stripping off my gloves. "Patient stable." Wallace nodded slowly. "Well done, Dr. Reed. That was remarkable." As we left the OR, I felt something I hadn't felt in 3 years. Hope. Mark Jennings opened his eyes 6 hours after the surgery. His vitals were strong, and his prognosis had suddenly been transformed from terminal to excellent. I was standing by his bedside, reviewing his charts, when his gaze focused on me. "You're the doctor who saved me," he said. His voice was rough, but it was clear. "I'm one of them," I replied carefully. "How are you feeling?" "Like I got hit by a truck." He managed a weak smile. "But alive. The nurse said I had injuries that should have killed me, that you did some kind of experimental procedure." I hesitated. "I used a technique that's not widely practiced. It was necessary, given your specific injuries." "Experimental," he repeated. "Sounds risky." "It was," I said, meeting his eyes. "But it was also your only chance." Before he could respond, Dr. Wallace entered the room with 3 other senior surgeons. I recognized them immediately as the hospital's medical review board, and I felt a sinking certainty. "Dr. Reed," Wallace said formally, "we need to discuss your unauthorized use of an unvalidated surgical technique." I had known this was coming. Success didn't just erase the fact that I had defied a direct order and performed a procedure that had previously resulted in a patient's death. "Of course, Dr. Wallace." In the conference room, the review board sat across from me like judges at a trial. There was Dr. Evelyn Grant, the head of surgical quality, Dr. Michael Chen, the chief of medical staff, and Ms. Laura Evans from hospital risk management. And Dr. Wallace, whose expression was carefully neutral. "Dr. Reed," Dr. Grant began, "we've reviewed the surgical records from Mr. Jennings's case. You performed a substernal cardiac repair using a technique that is not part of our hospital's approved protocols." "That's correct," I said. "A technique," Dr. Chen added, "that resulted in a patient death when you attempted it 3 years ago in a military setting." "Also correct," I said, keeping my voice steady. "I was reprimanded by the Military Medical Board and lost my field surgical privileges as a result." Ms. Evans leaned forward. "Yet you chose to use this same technique here, defying Dr. Wallace's direct order to use a standard approach." "I did," I said, looking at each of them in turn. "Because the standard approach would have failed. Mr. Jennings's injuries made traditional surgical access impossible. The substernal technique was his only chance of survival." But you couldn't have known it would work, Dr. Grant pressed, given your previous failure. I knew exactly why it failed before, I interrupted. I spent 3 years analyzing that surgery, identifying the precise moment where the complications occurred. The technique itself was sound. I had simply missed a secondary bleeding source that became critical during recovery. I pulled out my tablet and displayed the detailed analysis I had compiled over those 3 years: surgical diagrams, hemorrhage patterns, biomechanical models of cardiac trauma repair. This, I said, is why I was confident. Not because I was reckless, but because I understood my failure completely and knew how to prevent it. Dr. Wallace spoke for the first time. The board needs to understand something. I observed Dr. Reed's entire procedure. Her technique was flawless, her judgment was sound, and most importantly, she identified and corrected the exact complication that caused her previous failure. The room was silent for a moment. Dr. Wallace, Dr. Grant said carefully, are you saying you support Dr. Reed's decision to defy your direct order? I'm saying she saved a patient I had given up on. Wallace's voice was firm. I'm saying she demonstrated surgical innovation and courage that most doctors never develop, and I'm saying that if we punish doctors for succeeding where standard protocols fail, we'll never advance medical science. Dr. Chen studied me. Dr. Reed, if we validate this technique, if we add it to our protocols, can you teach it? Can you ensure other surgeons can perform it safely? I felt my heart racing. This wasn't a punishment. This was an opportunity. Yes, I said. I can develop training protocols, simulation exercises, guidelines for patient selection. I can make sure that what happened overseas never happens again. Not because we avoid the technique, but because we perfect it. The board members exchanged looks. We'll need detailed documentation, Ms. Evans said. A complete analysis of both your previous failure and your current success. Peer review, validation studies. You'll have everything you need, I promised. Then here's our decision, Ms. Evans said. You're not being disciplined for your actions with Mr. Jennings. Instead, you're being assigned to develop a comprehensive protocol for substernal cardiac repair with the goal of adding it to our hospital's approved procedures. I felt 3 years of weight just lifting from my shoulders. Thank you. Don't thank us yet, Dr. Wallace said with a slight smile. You just volunteered to prove that your technique works consistently, not just once. That means research, documentation, and training. And your first student will be me. As I left the conference room, I realized something profound had shifted. I wasn't the renegade doctor anymore. I was the innovator, the pioneer. 3 years ago, I'd failed. Today, I'd succeeded. Tomorrow, I'd teach others how to save lives that were currently considered unsurvivable. Sergeant Diaz was still gone, but his death hadn't been meaningless. 3 months. Later, I was standing in the hospital's simulation lab, watching Dr. Wallace practice the substernal approach on an advanced surgical mannequin. Around us, 6 other surgeons waited for their turn. This was the first cohort of doctors learning the technique that had been my redemption. Angle the retractor more superiorly, I instructed. You need clear visualization of the posterior cardiac surface to identify any secondary bleeding sources. Wallace adjusted his approach. The fiber optic monitor showed improved access. Like this? Perfect. Now you can see the vessel that would have been hidden with standard positioning. Over the past 3 months, I had worked tirelessly to develop comprehensive training protocols. I'd created surgical simulation scenarios, written detailed technical manuals, and consulted with cardiac specialists nationwide. The substernal technique was slowly becoming validated, recognized, and accepted. Dr. Reed, Dr. Grant entered the lab. I have news. The Journal of Trauma Surgery accepted your paper. It'll be published next month as the lead article. I felt a surge of pride. My detailed analysis of the failure overseas and the success with Mark Jennings had been peer-reviewed and validated by the top trauma journal in the country. "There's more," she continued. "Walter Reed Medical Center called. They want you to present the technique to their military surgical team. Apparently, field medics are encountering these injuries regularly, but have no good treatment options." My throat tightened. Walter Reed. The heart of military medicine. The place where my career had effectively ended 3 years ago. They want me to teach military surgeons? They want the doctor who turned a battlefield failure into a civilian breakthrough to come home and share what she learned. Dr. Grant smiled. "Anna, you're being invited back. Not as the doctor who failed, but as the innovator who succeeded." After she left, I stood alone in the simulation lab, surrounded by the equipment I'd used to perfect my technique. On the wall, I'd posted a photo of Sergeant Leo Diaz in his uniform, smiling and alive, taken 2 days before the attack that had killed him. "I figured it out, Sergeant," I said quietly to the photo. "It took me 3 years, but I figured out what went wrong. And now I'm going to make sure no other doctor makes the same mistake." My phone buzzed. It was a message from Mark Jennings. "Doc, 6-month checkup came back perfect. Cardiologist said my heart function is completely normal. You gave me my life back. Thank you." I smiled and typed back, "You gave me something too, Mark. The chance to prove that failure isn't final. Keep taking care of yourself." Dr. Wallace found me still standing there when he finished his simulation run. "Thinking about Walter Reed?" he asked. "Thinking about everything," I admitted. 3 months ago, I was the doctor nobody trusted, the renegade who'd killed a patient with experimental techniques. Now I'm being asked to teach at the most prestigious military hospital in the country. "You earned it," he said, "not by succeeding once, but by learning from failure so completely that success became inevitable." He paused. "Anna, can I ask you something? When you were standing over Jennings, knowing you were about to try the technique that had already failed once, were you afraid?" "Terrified," I said honestly. "But I was more afraid of not trying, of letting someone die when I knew a way that might save them. That's what separates good doctors from great ones," Wallace said. "Good doctors follow protocols and minimize risk. Great doctors take calculated risks when lives hang in the balance. You're great, Anna. You always were. It just took you 3 years to prove it to yourself." After he left, I began preparing my presentation for Walter Reed. I would tell them about Sergeant Diaz, about the failure that had destroyed my confidence, about the 3 years of analysis and doubt, and about Mark Jennings and the second chance that had changed everything. But most importantly, I would teach them the technique, the substernal approach that could save soldiers with injuries currently considered fatal. I would turn my greatest failure into my greatest contribution to military medicine. "This one's for you, Sergeant," I said to the photo, beginning my work. "Because some failures are really just lessons waiting to be learned. Some endings are really just beginnings in disguise. And sometimes, the renegade doctor is exactly what medicine needs. Someone willing to risk everything to save lives nobody else can save." 6 months after Mark Jennings' surgery, I was standing in the main auditorium at Walter Reed Medical Center, looking out at an audience of over 300 military medical professionals. There were surgeons, field medics, trauma specialists, and medical commanders, all gathered to learn from the doctor who'd once been drummed out of military medicine. 3 years ago, I began. I stood in a field hospital trying to save Sergeant Leo Diaz. He had massive cardiac trauma, and I attempted an experimental substernal repair technique. I clicked to a slide showing Diaz's smiling photo. Sergeant Diaz died on my operating table. The technique failed, and I was ruled unfit for military surgical practice. The audience was silent, attentive. For 3 years, I carried that failure. I questioned every decision I'd made. I wondered if I'd been reckless, dangerous, unworthy of the trust patients placed in me. My voice was steady. but I also spent those 3 years analyzing what went wrong. Not to excuse myself, but to understand completely. I clicked through slides showing the detailed surgical diagrams. What I discovered was that the technique itself was sound. My execution was the problem. I'd missed a secondary bleeding source, hadn't accounted for battlefield conditions affecting coagulation, and had rushed when patience was required. Another click. Mark Jennings's before and after scans. 6 months ago, I faced the same injury pattern, the same impossible anatomy, the same technique required. But this time, I knew what had killed Sergeant Diaz. I knew how to prevent those complications. I walked them through the entire Jennings surgery, highlighting each decision point, each moment where my 3 years of analysis had informed my approach. The substernal technique saved Mark Jennings's life, but more importantly, it validated what I had learned from failure. Sergeant Diaz's death taught me how to save lives. I just needed 3 years to fully understand the lesson. I paused, looking at the military medical professionals who had once been my colleagues. I'm here today not to glorify failure, but to show you that failure can be the greatest teacher we have if we're brave enough to learn from it. The next hour was technical. Detailed surgical demonstrations, training protocols, patient selection criteria. I had prepared comprehensive materials, but the real message was simpler. Learn from mistakes. Adapt techniques. Never stop questioning. During the break, a young Army surgeon approached me. She was Lieutenant Kate Jensen, fresh from her first deployment. Dr. Reed, I lost a patient last month. Similar injuries to what you described. I tried everything I knew, but nothing worked. Her voice was tight with emotion. They're reviewing my case, questioning my decisions. I feel like my career is over. I saw myself in the young captain's eyes, the guilt, the self-doubt, the fear of being labeled incompetent. Lieutenant Jensen, your career isn't over. It's being tested. The question is, will you let this failure define you, or will you use it to become a better surgeon? I handed her a card. Call me. I'll help you analyze what happened, understand what went wrong, and make sure you learn everything possible from this experience. Her eyes filled with tears. You'd do that? After everything you went through? Especially because of everything I went through, I said. I spent 3 years alone with my failure. I won't let another military surgeon go through that if I can help. The afternoon session focused on hands-on training. I had brought surgical simulation equipment, allowing the military doctors to practice the substernal technique in realistic scenarios. The key, I instructed, watching a field surgeon work through the procedure, is patience. In combat zones, we're trained to work fast, but this technique requires methodical precision. Speed comes with practice, but accuracy must come first. By the end of the day, 12 military surgeons had successfully completed the simulated procedure. That was 12 more doctors who could save lives in situations that were previously considered hopeless. As the conference concluded, Colonel Mark Bishop, the Chief of Military Surgical Services, approached me. Dr. Reed, I was on the board that reviewed your case 3 years ago. I voted to revoke your field privileges. He extended his hand. I was wrong, and I'm sorry. I shook his hand, surprised. Colonel, he said, his voice firm, you innovated under pressure to save a soldier's life. The fact that Sergeant Diaz didn't survive doesn't change the courage of your attempt. We failed you, Dr. Reed. We punished innovation instead of learning from it. Today, you taught us that lesson. Thank you. After he left, I stood alone in the empty auditorium, looking at the photo of Sergeant Diaz, still displayed on the main screen. We did it, Sergeant, I said softly. Your death wasn't meaningless. Today, 12 doctors learned how to save soldiers with your injuries. In 6 months, maybe 50 more. In a year, maybe hundreds. My phone buzzed. It was a message from the Military Medical Review Board. Dr. Reed, we're offering you a consulting position with Military Medical Services, a part-time advisory role helping develop innovative combat medical techniques. Interested? I smiled. 3 years ago, they had thrown me out. Now they were asking me to come back, not as a field surgeon, but as an innovator, a teacher, a bridge between military and civilian medicine. I typed my response. Interested, let's discuss terms. Because some stories don't end with failure. Some stories use failure as the foundation for something greater. Sergeant Diaz was still gone. That would never change. But his death had taught me how to save countless others. And that was a legacy worth building on. 1 year after Mark Jennings's surgery, I was standing in my new office at the Institute for Advanced Trauma Surgery, a collaborative center I had founded between Walter Reed and my home hospital. The walls were covered with photos. Sergeant Diaz, Mark Jennings, and the 43 other patients who had been saved using the substernal technique in the past 12 months. Dr. Reed, my assistant knocked. You have visitors. Mark Jennings entered, walking strongly, looking healthy. Behind him was a woman I didn't recognize, and a young girl, about 8 years old. Dr. Reed, Mark smiled broadly. I wanted you to meet my wife, Sarah, and my daughter, Lily. Lily, this is the doctor who saved Daddy's life. The little girl looked at me with wide eyes. Daddy said you did a magic surgery that other doctors couldn't do. I knelt to Lily's level. Not magic, sweetheart. Just medicine that required trying something new. Your daddy's heart was hurt very badly, but we found a way to fix it. Daddy says you're a hero, Lily said seriously. I felt my throat tighten. Your daddy's the hero. He fought very hard to stay alive. After they left, I stood at my window, looking out at the hospital where Mark had nearly died, where I'd risked everything on a technique that had already failed me once. Dr. Wallace entered without knocking, a privilege of friendship we'd earned over the past year. Still thinking about that day? He asked. Always, I admitted. It was the scariest moment of my career. Standing over Mark, knowing I was about to try the technique that killed Sergeant Diaz, wondering if I'd learned enough to prevent history from repeating. You know what the real courage was? Wallace sat down. Not that you tried the technique. Any reckless doctor might have done that. The real courage was that you had learned from your failure so completely that you could trust yourself to try again. I nodded slowly. I spent 3 years terrified of making the same mistake twice, but I realized that the only way to honor Sergeant Diaz's death was to learn from it, to become the surgeon who could succeed where I'd failed. And you did more than succeed, Wallace gestured to the photos on the wall. You created a legacy. 43 patients saved, 57 surgeons trained, a technique that's now being taught in medical schools nationwide. It's not about the numbers, I said. It's about the little girl who still has her father. About Lieutenant Jensen, who I've been mentoring, who just successfully performed the technique for the first time. It's about turning the worst moment of my life into something that helps others. My phone rang. It was Lieutenant Jensen. Dr. Reed, I just saved my first patient using the substernal approach. A female soldier, IED blast, cardiac trauma. I saw the secondary bleeding source this time. I remembered everything you taught me. Her voice was jubilant and relieved. She's going to make it. That's wonderful, Kate. You did great. I did what you taught me. I learned from my failure, and I used that knowledge to save a life. She paused. Dr. Reed, thank you. For not letting me give up on myself. For showing me that failure isn't the end. After hanging up, I felt something settle inside me. Peace, perhaps, or acceptance. Or simply the understanding that some journeys require detours through darkness before reaching the light. Dr. Wallace, I said, remember when you told me there was no more hope? When you'd given up on Mark? I remember. I've been thinking about that moment, About how hope isn't about odds or statistics or conventional wisdom. Hope is about being willing to try something that might not work, because the alternative is accepting defeat. I smiled. You taught me that, by letting me try, even though you thought I'd fail. Wallace stood. I didn't let you try because I thought you'd succeed. I let you try because I saw a doctor who had learned from failure so thoroughly that she deserved a second chance. And you proved that second chances matter. As he left, I returned to my computer, where I was writing a new paper. From battlefield failure to clinical success, the evolution of substernal cardiac repair. In it, I detailed everything: Sergeant Diaz's death, my 3 years of analysis, Mark Jennings's salvation, and the 43 patients who had benefited since. I didn't hide the failure. I celebrated the learning, because that was the real story. Not that I'd failed once and succeeded later, but that I'd failed, learned, adapted, and transformed a catastrophe into innovation. My office door opened again. This time it was Mark alone. "Forgot to give you this," he said, handing me an envelope. Inside was a photo of Mark with Sarah and Lily, all smiling, healthy, and alive. On the back, handwritten, "To Dr. Reed, who gave me the chance to be a father again. Thank you for not giving up hope. Mark." I placed the photo on my wall, right next to Sergeant Diaz's picture. 2 men. One had died despite my best efforts. One had lived because I had learned from that death. Together, they told the complete story of Dr. Anna Reed, the renegade doctor who'd turned failure into wisdom, defeat into victory, and despair into hope. "There's no more hope," the chief surgeon had said. "I still know a way," I'd replied. And in that moment of defiance, of courage, of willingness to risk everything on knowledge earned through failure, I'd saved a life. Not just Mark Jennings' life, but my own as well. Because sometimes saving others is how we save ourselves. And sometimes, the renegade doctor is exactly what medicine needs. Someone brave enough to try again, smart enough to learn from failure, and compassionate enough to turn tragedy into triumph. One life at a time, one lesson at a time, one second chance at a time. That was the legacy of Dr. Anna Reed, and it had started with a simple declaration: "I still know a way,